committee for inviting me. I'm really honored to be here and in the presence of all the giants in Pompe disease and the amazing patients and families. So I'm really, truly honored. These are my disclosures. So I am the PI for the Natural History Genzyme Registry at UC Irvine. I am on the Pompe Registry on Board of Advisors. Oops, didn't mean to do that. The genotype phenotype working group, and I have received ISS funding for an exercise study in Pompe disease. So we've all heard about registries. Why do we need registries? And these are some of the advantages. So it provides a way to really study the breadth and the depth of Pompe disease, whereas in clinical trials they're looking at a very specific subset. It helps us uncover new aspects of the disease that we didn't know about, and helps us monitor a whole bunch of aspects, the signs, the symptoms, how to diagnose, and effects of management, and so forth. So it's purely observational. Of course, we're testing antibodies as part of it. There's a recommended set of testing that Genzyme has, and we monitor every 6 months for a whole bunch of things like 6-minute walk test, respiratory function, fatigue scale, etc. that you heard about. Is purely voluntary. And the requirements are either 2 mutations that are disease-causing or a diagnosis by enzyme by blood test or in a skin fibroblast study. So it's running away from me. So this is the most up-to-date worldwide distribution of patients. So there are 2,000 patients in 37 countries, 230 sites, with 6 publications thus far. And what you see in blue is those countries where patients are represented. And there's a huge part of the globe in which there are no patients represented. And of course, this is a travesty. The purpose of the registry is functioning as a platform for partnering international collaborations that you've already heard about, networking with patients, the physicians, researchers, and of course our industry partners, which are very important. So the Pompe Registry comprises of an international board of advisors, and many people here are on that board. And then the 4 parts of the globe are represented, such as the North American Board of Advisors, Japan, Asia, the European, Middle East, and Africa, and then the Latin American Board of Advisors. And they determine what priorities are. They review requests for data and what are publication priorities, etc. So these are the 4 abstracts that have been presented in the last year at various meetings that you see here: the World, ACMG, the MDA, and SSIEM. And these are the titles of those presentations. I'll let you read, or if you don't want to read, just admire my brand new grandson, who's aged 3 months, and he lives in Sydney, Australia, and I miss him. So this is the distribution up to date as of September 6, 2019. And you can see here the vast majority of patients that you already heard about are the LOPD group. In blue is the IOPD, and then a significant number, 11%, in which it's 11% unspecified thus far. And just to remind you that the way these groups have been determined is the LOPD group, so we'll start with the IOPD group, includes individuals who are less than 12 months when they're diagnosed with cardiomyopathy, and then the LOPD is over 12 months. And in our studies, we've also subdivided those into group B and C. If they don't have cardiomyopathy and diagnosed under the age of 12 months, then they're B, and greater than 12 months and greater than 12 years is group C. So this is the geographic distribution again, and you can, actually I think I've presented this already. So this is the European Middle East, so I'm going the other way. So here you see is the patient demographics. So although we started with 2,000, because of insufficient data, we have a total of 1,705 patients in which we have enough data to study the demographics as of September 6, 2019. So what you see here is the age at symptom onset in all patients was 23. In the IOPD group, it's 0.2 years, and the LOPD 28. And the age of diagnosis, it's 0.3 years, but significantly older at in the LOPD group. And then, if you look at group B, in which they are symptomatic below 12 months, but don't develop cardiomyopathy, the gap between symptom onset and age of diagnosis is much greater. So you already heard from Dr. Reuser about how to cook up the GAA enzyme, which is a protein, and there are many variants that result in Pompe disease. A variant is a generic term used for either disease-causing mutations or VUSs, a variant of uncertain significant, and these are something that it takes a lot of work sometimes to work through. So these are the different types of mutations: missense mutations, in which there is a substitution. A silent mutation doesn't change the amino acid, and generally they are not considered significant. When you hear the word nonsense or frame shift, then those are usually severe, because it's producing a stop codon very often, and there's no protein being translated from that genetic mutation. And then there are insertions or deletions or duplications of big regions. So there are many, many different types of mutations. And this table here from a publication that Dr. Reuser is the first author of just a few months ago in Human Mutation, and it's been a tremendous catalog for newborn screening variants that are identified where you have no information, and you can go to this catalog and try and learn about what the possibility would be of that phenotype resulting from that genotype. So what you see at the top are all patients. Of all patients, those are the number of variants that have been identified, 275, and then these are the different variants in each of those three different groups that I mentioned. So of those 275 total known variants, 1981, I'm not sure if I have a pointer, but my mouse doesn't work. I don't have a pointer, okay. So there are, of those 1981, there are 318 discrete mutations. So the 1981 is total, and there are 312 types of mutations that are known. And the 94 is novel variants. So they have never been seen before in the Erasmus database or the Duke database. And of those 94, 80 were discrete mutations. 94 were the total number seen. What you see further down is that there were 969 out of this total number that had patients who had 2 or more mutations. And, oh, thank you. What was that? I don't think anywhere is going to work right now, but you'll have to follow my instructions. So patients with one variant, actually there was a big group of patients, 110. We're just looking at the all patient group over there. There were 110 patients that had one variant, but that didn't mean that they didn't have Pompe disease. They had Pompe disease diagnosed by enzyme deficiency or, looking at muscle biopsies. And the methodology wasn't there to detect all those variants because the type of testing in different countries is very different. You may not have very comprehensive testing in certain places, but hopefully as time moves on, we're also determining that what was considered a VUS, a variant of uncertain significance, as we get more data, they're being reclassified as pathogenic mutations. These are the 5 common variants in each of those 3 categories that were reported. Of course, it's a huge catalog with a lot of variants, but things that I wanted to point out to you is that you see the common variant that you heard about, the common splice site that Dr. van der Ploeg very elegantly told us how it causes the missplicing and removal of exon 2 from the actual protein, the enzyme. That is never seen in group A, which is not surprising because it's it's one of the mildest mutations in which there is 10 to 20% of enzyme produced. So if you have that, you're unlikely to have the infantile type. The other things I wanted to point out that there are certain variants that are seen in the 3 groups, but they're the top 2 variants in the group A are not seen in the top 5 group B and group C variants. So what is known about these GA variants? So looking at the infantile onset variants, the first one, the 2560C to T, which results in a frame shift, which results in a stop codon. When you see an X at the end of the protein, that means that protein is not formed, so it's truncated, and generally it means it's severe. And what's interesting is that this is a founder mutation that comes from Africa, and it started from North Africa along the west coast to South Africa, and then with the slave trade, it was brought to to Americas, and it's commonly seen in the African American population. The other mutation, the 1935 C2A, is also a founder mutation seen commonly in the Taiwanese Chinese population. And it causes infantile onset, very severe type. And then these other 2 are also on that list of common variants, which are particularly seen in the Dutch population. These are, I mustn't forget to talk to you about the pseudodeficiency alleles. So it is important not to misdiagnose patients, because when you look at these mutations in the lab, they are just like the actual pathological GA variant, but they produce no phenotype. And these 2 variants on the left actually go together in cis, which means they reside on that same chromosome, on the same allele, but obviously have absolutely no phenotype. So these are the common LOPD variants on that list that you saw, and the first one is by far the most common. There's common splice mutations, when you look at that particular mutation in combination with another mutation, you see a huge variety of phenotypes, and especially with the null type, it may actually cause quite severe. And Priya has presented patients with early onset muscle weakness with that splice mutation and a very severe second mutation. Dr. van der Ploeg mentioned that there are people who are absolutely without any features of Pompe disease who carry 2 of these splice size mutations. But obviously there were many patients in the type C who were, there were also 11 patients who were homozygous in the types, in the group C Pompe disease registry, sorry. So of the patients that had the novel mutations, they're spread all over the place, as you see here. So in the black were people who had mutations which apparently didn't change the protein that was involved with Pompe disease. So because they were novel, there was nothing to go by, and so we tend to use programs such as SIFT and Polyphen to predict how severe or how significant these variants are, and you can predict sort of their severity. Of course, doing CRIM testing will tell you whether they are in the infantile Pompe category or the later onset category, but in time will tell with some of these novel variants. So I at UC Irvine have been very fortunate to be able to have one of these registries, and it has been a great springboard to actually study patients. We have about 24 patients, and we recently published our experience with our 18 patients with late onset Pompe disease. And I tried to look to see what was the effect of enzyme. And there isn't an arrow there, but where you see a difference in the slope, that was when enzyme was initiated in the patients. Very limited data was available before enzyme initiation in many of the categories, but you can see that there was significant differences before and after. For example, in the FVC in the top right, and a little bit in the so it was supine and erect. I can hardly see my screen here. And for the other factors, there really wasn't enough data, but compared to the natural history, this represented a significant improvement. We had one individual who actually had an aneurysm, as you see here on the bottom right. He had to go 3 times to the emergency room in order to get any attention, but he did very well after his aneurysm had leaked and he had a clip placed. And this is something that, knowing the natural history of this disease, perhaps we should be more on the lookout for factors such as the incidence of aneurysms in Pompe disease. What you see on the bottom left is our patients' mutations. They're all over the place. Some of them were novel. We actually did get a call from a newborn screening site where they wanted to know about one of our novel patients' mutations, and we were able to give them information which was very helpful for counseling. So this is a real quick run through the registry. I hope I provided you some information that was useful on the registry, the value of using it to study common as well as novel variants, try to establish genotype-phenotype correlation, and helps us monitor progression of the disease. This is my grandchild number 2 and my grandchild number 3. Thank you.